So good morning. We're going to talk about the impacts that cognition is going to have under Pdpm, and we are going to start with a recorded video from CMS on cognition interviews.
The purpose of the first interview section in MDS 3.0 is to assess the resident's cognitive patterns. The brief interview for mental status efficiently provides insight into the resident's current condition and helps to identify needed supports. Most residents are able to attempt this brief interview for mental status. Without an attempted structured cognitive interview, a resident may be mislabeled based on his or her appearance or assumed diagnosis. Now we will demonstrate an interview. Score the interview as you watch. To do this, you need to know that it is Monday, November the 23rd, 2009. Before watching and scoring the interview, review the coding instructions in the manual.
Mrs. Jones. Mrs. Jones. Mrs. Jones, I'd like to ask you those questions now. We ask these questions of everyone, and we do it so we can better plan your care. Some of the questions may seem easy, others more difficult. Are you ready? Okay. I'm going to say 3 words for you to remember. Please repeat the words after I have said all 3. The words are sock, blue, and bed. Now tell me the 3 words.
Bed.
Blue. Blue is my favorite color.
Okay. Yes, 2 of the words are bed, a piece of furniture, and blue, a color. The 3rd, sock, is something that you wear. Now tell me the 3 words.
The blue socks are on the bed.
Okay. Now can you tell me what year it is right now?
Don't you know?
We ask these questions so that we can better plan your care. Please tell me the year we're in.
1999, the millennium.
And what month is it?
November. My grandchildren made that turkey for me.
Oh, very creative. And what day of the week is it?
Monday. Monday, we play bingo. It's Monday.
You play bingo on Monday?
Monday.
Wonderful. Now let's get back to the earlier question. What were those 3 words I asked you to repeat?
Blue.
Okay. And something that you wear?
Dress.
Okay. And a piece of furniture?
Bed.
Okay. Now I'd like to ask you some questions about your mood. Would that be all right with you?
So you can see that interview that's been there since 2010. That has not changed since we've started to do it. So it's a nice little reminder, or for people that are new to your roles, you'll be able to take a look at that. But it is very distinct and it's very standardized, and you want to follow that script to the letter. So Medicare's payment methodology is changing effective 10/1/2019, and you should already be hearing discussions about PDPM, which stands for Patient Driven Payment Model. Under this model, therapy services are no longer going to be the driving component of how we get paid for each Medicare resident. Instead, each Medicare resident's rate is going to be individualized and based on their full clinical picture, with thousands of possible rates. In fact, hundreds of thousands of rates. So right now, under the Medicare system, we have 66 different rugs, and you're familiar with RUCs and RVXs and all of those types of things, 66. But now, as of 10/1, based on all of the combinations, there are hundreds of thousands of different rates that could come up for any individual patient. The role of the social worker in long-term care is broad. Your knowledge and diligence has an impact on many clinical, psychosocial, and financial outcomes. Quality measures related to the antipsychotic meds impact our 5-star that's used for contracts with managed care. Survey results related to mood, behaviors, room changes, grievances, allegations, and care planning. A financial impact related to safe discharge planning that assists us with avoiding rehospitalization rates that could lead to a full year of Medicare rate reductions. Marketing impact related to those safe discharge plans, arranging community services, and perhaps follow-up calls after someone has discharged from the facility. And then most importantly, the impact you have on residents' rights, their quality of life, and as an advocate for that patient. Under Pdpm, you now will have an additional impact that is more directly related to the reimbursement rate for the Medicare residents. But let me lead with even better news. Beginning 10/1, there's no longer going to be 14-day, 30-day, 60-day, 90-day COTS, end of therapies. None of those assessments are going to be required. You're only going to need to complete a 5-day, which may or may not be combined with an admission, and either an end of PPS or a discharge MDS for your Medicare patients. You're still going to need to complete the OBRA-related assessments, such as the quarterlies, annuals, and SIG changes for all of the other folks. Your direct impact on the reimbursement rate effective October is related to BIM scores, or the CPS scale when a BIM interview cannot be completed, as well as the frequency of depression symptoms. And for the purpose of this session, we're only going to be addressing cognition. During the month of April, your regional reimbursement nurses are going to be focused on BIM scores, CPS, interview processes. They're going to complete remote audits as well as on-site visits, and they may request to accompany you on interviews and provide additional education on this topic at that time. Unless a resident is rarely or never understood, you heard CMS say they believe all residents are interviewable. So unless the resident refuses, an interview should be attempted. BIM scores under 13 are going to impact one of the components of the rate that is under speech therapy. And then if it's less than or equal to 9, that has an additional impact in the nursing component of the rate. It is considered cognitively impaired for this score. My suggestion is that you print out one of these section C's and laminate it. Have it with you, have multiple copies laminated, and use a dry erase marker as you conduct the interview. We've been doing these for several years now, and a lot of people have probably gotten very familiar with the questions, and you sit down without having this script, if you will, and you ask the questions perhaps in different order or using different terminology, all right? If we use this and we don't get creative and just stay with the words and the phrases that they put, that's when it's a standardized assessment. When everybody's going in and asking it in different order, using different terminology, then it is no longer standardized. And that's what this is meant to do. That was CMS's intent, so that we can use this data down the road, perhaps 3, 4, 5 years later, in something else that they're developing in regards to standards of care. So again, I would suggest that you make a copy of this. If you don't have a laminator, take shipping tape and put it over the whole page and keep it on a clipboard. And when you're ready to do interviews somewhere, you have a dry erase marker, you do it, then you can erase it later and you don't have to keep making a bunch of copies and have them float around. If the resident interview is not conducted within the look-back period, then you have to code yes that it should have been conducted and that the standard information code is used. So you're going to be putting dashes in the interview items if it should have been conducted and it wasn't. The RAI manual is very specific to say do not complete staff assessment for the mental status items if the resident interview should have been conducted but was not. That's why it's very important to know when someone has a planned discharge or to get those assessments in the computer as soon as possible so that you have time to do the interview before the person gets discharged. Once they're discharged and an interview should have been done, you have no alternative to put dashes, and that is going to impact us in several different fashions, financially for sure. So when should you respond with zeros? You're going to code 0, no, if the resident cannot recall the word, even if after being given the cue. If the resident responds with nonsensical answers, or if the resident chooses not to answer the item. So when people were refusing, sometimes people were putting dashes there. You would not put dashes, you would put a 0 because the person refused to answer. You stop the interview before it is complete in these situations. You stop it after completing the question day of the week if all the responses have been nonsensical, or there has been no verbal or written response to any of the questions up to that point, or there has been no verbal or written response to some of the questions, and the ones they did answer were nonsensical. That's when you would stop the interview. If you stop it, you would code a dash in C0400 A, B, and C, and put a 99 in the summary score in 500. You're going to code 1 yes in C600 that the staff assessment should be conducted. And then you would complete that staff assessment based on interviews with staff and information that's available in the medical record. When you don't do a BIMS, when it can't be completed, then the MDS bases itself on the CPS. So cognitive performance scale, and it is derived from the staff assessment answers when a BIMS can't be completed. It is a 6-point system, and anything greater than 0 under Pdpm is considered to be cognitively impaired. So the MDS questions that are used to calculate CPS is B0700, is the resident understood? Staff assessment for mental status, does the patient have short-term memory impairment? And cognitive skills, their decision-making skills. So again, the 3 questions that are used to calculate a CPS in the absence of a BIMS interview is whether or not the person makes themselves understood, whether or not they have short-term memory loss, and what their decision-making skill level is. So I talked about the fact that there are different components of the Pdpm rate. And the ones that are case mix driven, there's speech therapy, physical therapy, occupational therapy, nursing, and what's called an NTA. And those are things that you don't necessarily need to know more in depth, but you need to know that your ability to code this appropriately for cognition has an impact on both the speech component and the nursing component alike. So Pdpm is a CMI-driven system. The higher the person's CMI in a category, the higher the reimbursement for that category is going to be. So when we look at speech, there are several different factors that create the person's speech rate. Having a neurological condition, having a speech-language comorbidity, and then having impaired cognition are 3 of the 5. You will see that if they have none of those, as well as having no diet or swallowing problems, then their lowest CMI would be 0.68. And that's what the resident would get for their CMI for the speech component. So they have nothing, none of those things. By simply adding just the impaired cognition, so the BIM score or the CPS indicates that this person has impaired cognition, it will raise that CMI from 0.68 to 1.46 for this component. Now you can't see the dollar amounts right now, but just look at that CMI alone and you can certainly see that this is going to be higher payment because the CMI is higher. Under the nursing component, the BIM score, if it's less than or equal to 9, they're cognitively impaired, and they would classify into a behavioral symptom and cognitive performance category. So with the RUGs, the 66 that are there now, we are still going to have all of those lower level ones that weren't rehab. And we have the PA1, which you're probably familiar with, and that CMI is 0.66. And adding cognition to someone, impaired cognition, could move them to a BA, B1 category, and their CMI is going to be 0.99. These are the questions that are being asked. The resident's cognitively impaired if one of the 3 following conditions exist. They are comatose and completely ADL dependent. They have severe impaired cognitive skills. Answer 3 at C1000. B0700, C0700, or C1000, 2 or more of these impairments are present. So they have a problem being understood, they have a short-term memory loss, and they have impaired cognitive skills. And then severe impairment would move them up if they had one or more of the following problems. So we're going to take a look at the financial impact of moving these CMIs. So these are those two tables that I showed you. This first larger one is for speech and the second one is for nursing. Your impaired cognition can impact both of these for every single resident that you work on. So remember we talked about the lowest CMI for speech being 0.68. That would be $15.06 per day related to this person's rate for the speech therapy component. Adding that impaired cognition moves that CMI to 1.46. Watch what happens to that $15.06 here when we hit that. It doubles, $32.34, simply by making no other change except for the fact that you've identified cognitive impairment. Then you look at the nursing, and we talked about it being at the lowest CMI of 0.66. $68 part of that rate every day for the patient. By you capturing impaired cognition, and we move this to 0.99, watch the $68. It now becomes $102. That's $34 a day. So just by capturing this, you have the potential to minimally capture about $45 per day on top of what else is going on with the patient. So it's very important for us to make sure that these interviews are set up in the system, that they're completed timely, that we avoid the use of dashes because we complete them timely, and above all, that they are accurate.